So for mechanism of injury, what I will say is I am one of those people who are not very good at this, all right? As far as when we get to car accidents anyways, understanding like what happened in this car crash. There's other people that are much better at it than I am. I tend to focus on where the patient is and then I'm just around the patient. There's very often after car accidents and such, I would like have no idea. I'd have to ask my partner, like, what kind of car were you driving? And can you tell me what happened? Even when I was training people, I would say, you figure this out. I knew what I was doing. And you tell me what you think is going wrong. And something to remember is I'm not going to teach you accident investigation or recreation or any of that kind of stuff. So what I see sometimes is people will either narrate or when they're talking to a nurse, when they're doing the turnover, they'll say something like the patient was going 45 miles an hour or 55 miles an hour or 70, or all of the patient was at the time of impact was doing this and that. You don't know that stuff, all right? You really don't, unless you are a former police officer. I would guess is what the only persons that I can think of that would know that. You could be a police officer, it doesn't have to be former. And you went through a whole accident recreation kind of thing. When we're narrating or when we're talking to somebody, we should use facts. Like, you can say stuff like, the speed is posted at this. You could say the patient says this is how fast they were going, but we shouldn't get into the thing like there was this much of, he was able to brake for this many feet and all of those kind of things. It's not helpful, and very often when we get called into court, it's car accidents. And when you write stuff that you can't support with any real data, you're going to kind of get torn up by an attorney. That attorney wants to make it seem like you don't know what you're talking about. That's the way they will do it, all right? So keep with the facts. You can get stuff from the police sometimes, but it's kind of like usually you can't. You're too busy to sit and talk with police officers. Regular Joe Blow police officers very often don't know in an emergency phase exactly how accidents happen. They're still doing their investigation. And you usually aren't going to go around to the crowd and say, hey, does anybody see this? Do we have any witnesses that can help me do this? It's just not going to happen. And another thing that comes up a lot is people will say different words that don't really mean anything. And those words are things like, there was minor damage to the front, there was moderate damage to the front, there was extensive damage to the front. All of those things are not the best way to describe stuff. I do them. I can't say that it's impossible for you to ever do this and it's a dumb thing to do or anything like that, but much better way of doing it is to tell them what you see, all right? Like 1 foot of encroachment into this, the engine got knocked off from it's the way they hold the engine in onto the frame. All of those kind of things, data, starring of the windshield, the seat was knocked off from where the seat is supposed to be. Those are much better data. That tells you how the energy was applied. So using the things that you'll get from those discussion forums where you're going to crash, EDU, that kind of stuff is good, like principal direction of force, all of those kind of things. That's what they want to hear in your, like at Butterworth, I think they probably do a pretty good job at this, and St. Mary's, I guess too, where you have 60 seconds, you have 60 seconds of silence, and at that point, you want to be able to tell them stuff that they really need to know. Extensive damage is your extensive damage isn't the same as my extensive damage. It depends on your experience, right? Like I've seen some pretty horrendous, cars cut in two by other cars or by trees or by trains or whatever. That is extensive. Extensive seems like the biggest word, the best one that you like for the worst kind of thing. It's better to say, this is what was happening. The windshield was starred, the steering wheel was bent, there's a foot of encroachment, the principal direction of force was this way. All of those things are much better. If you want to talk about speeds, you can say, patient states they were going this fast, or The speeds are posted like this, all right? This is the kind of intersection. Those kind of things paint a picture for the trauma team. And for us, like I was saying at the very beginning, I don't do this very well. When we're talking about car accidents, which is I think is the most of what we're going to talk about is car accidents. The reason, and I used to just poo-poo mechanism of injury, I'd be like, who cares? And truly, even when I first started training or teaching paramedics, I never really talked it. I would kind of skip the mechanism of injury chapter, talk a little bit about trauma systems, and that's it. And now, and it's Dr. Wang from the discussion forum things who's kind of changed my opinion. Dr. Wang talks at our conferences very often. You'll see him at EMSIC conferences and the EMS Expo. Now, when I look at things, I really still do kind of a bad job at it, but I totally understand, like, oh, that's why it's important. It is. It gives you, as a new paramedic student, this is what you need to know as far as answering National Registry questions, right? Is it gives you a more effective way to use your time. When somebody is hit, if they're a driver, they're hit on the driver's side, lateral impact, this is where you should spend your time, all right? They probably don't have a lot of damage on this side. It doesn't say you don't look at that side, but it should give you a focus like, let's make sure on this side, he probably has an intact humerus. But on this side, I'm really going to make sure that that humerus and the radial ulnus are good to go. Same thing for maybe on the pelvis, you'll look on this side, on the femur, whatever it would be, you're going to spend a little bit more time. The same thing can be said when you're talking about gunshot wounds, like you know that they were shot, and this is something like that you get from police fairly early on. It's not hard. They know usually we're looking for somebody who he was shot with a 38. It's a 38 small revolver, all right? They know that it's a 9mm, a shotgun, an AR, whatever it would be. The cops usually know that right away. Like when we're on scene, it's not hard to say, do you know what he was shot with, all right? So it's not like we're dreaming to like, well, we would never know that until the next day. And some, Sherlock Holmes came and figured out what kind of gun was used. They usually know a good idea right away. And so when you're taking care of the patient, you're like not even up to the patient yet, and you know, all right? Because very often on those, the cops have been there. They cleared the scene, now you're on the scene, and they've seen, oh, look at all these spent casings. This is what he got shot with. So if you have someone who's shot from a distance with a 38 revolver, you're probably not going to have exit wounds. You shouldn't like spend a lot of time thinking, oh, I'm going to have an exit wound. But if there's an AR or let's say an AK, and they're shot from inside the same room, you should be looking for an exit wound right away, all right? So those kind of things, mechanism of injury can tell you quite a bit, to focus your assessment and make you more efficient. Trauma, #1 death for 1 to 44. We're going to talk about this, basically laws of energy and kinetics here. So we need to know about kinetics, how the body will absorb energy as it's placed on it is kind of where we focus on, or is what we're going to focus on anyways. Understanding all of these does make sense. So we're going to spend some time today talking about it, but then we're going to drop it. We're not going to see a lot of quiz questions and not a lot of test questions. Almost all of the time, it's kind of common sense. If you're a passenger in a car that was hit on the driver's side, you're doing pretty good. All right. When you're at a frontal, you can go this and you can go this, and the injuries are pretty predictable. Rear end crashes, and we already did some of this in the patient assessment thing way back in the trauma area of preparatory. So this stuff we're going to talk about it a little bit, quiz a little bit. Test questions are fairly easy, common sense kind of stuff, no tricks. So kinetic energy, I think the question was half the mass times velocity squared was the answer, right? And usually when you're talking about kinetic energy, the discussion really is in ballistics. We're basically saying big bullets moving slow are not as bad as small bullets moving fast. That's why we have this thing here. On the National Registry and test questions and such, you'll see that they almost always have it as a non-ballistics thing. They'll say a small car traveling this fast or a big car traveling that fast, and that's not what we're talking about for kinetic energy, because usually, you know, if you're in a big car, you're golden, right? You always want to be in the Suburban or the Excursion in the car accident. It doesn't matter how fast you're going, you're just going to run over stuff. It doesn't matter how slow or fast you're going in that little car, you're probably not going to do so well because there's just thinner metal, lighter car, all kinds of stuff. So the other way they sell it is, oh, you have a baseball traveling at this, or a hockey puck traveling at that. It doesn't matter what the mass is. The one that's going faster has more kinetic energy. It's that simple idea. And it goes, so you understand, bullets coming out of a long gun, a rifle or such, they go faster. So when people are shot with rifles, they usually have worse tissue damage. It's more energy applied to the patient. They're also going to have more chances of having an exit wound. So the law of conservation is just that energy cannot be created or destroyed. All right, Newton's first law. So this is quiz question, test question stuff. A body at rest will remain at rest. So Newton's first is at rest, remain at rest. Easy stuff. Second isn't probably going to be a question. All right, it's mass times acceleration equals force. Mass times acceleration equals force. Very often people don't associate this with him at all. They just say, what is the equation for force? Mass times deceleration is also force. But Newton's third law goes back to where you see this as questions a lot. And this is for every action, there is an equal and opposite reaction. It's kind of, this goes back to that first, and the third, I think, are kind of associated. And then kinetics, again, we go back to that same thing. Force equals mass times acceleration or deceleration. So it is force, all right? What force was applied to the body? And then our next thing is, where on the body was it applied to, all right? So we should be able to quantify that by saying, like, just factual stuff, like we were traveling at that, they fell from this, the bullets came out of this kind of gun, whatever it would be. And then where did it impact? Bullet into the head, the steering wheel into the chest, all of those kind of things. When somebody falls, they fall on their head. That, for us to narrate it, for us to communicate it, and while we're taking care of that patient, let's say this one who's burying her head into the grass here, we should not spend a lot of time checking out her feet, all right? We don't have to remove all of her shoes early on and make sure that all of her carpals are good, or tarsals are good, all right? Her tib-fib, fine. Her knees, probably intact. Her femurs, probably good to go, all right? All the way, and probably even her pelvis is pretty safe, all right? What we have to worry about is head injuries and neck injuries. I don't think you need to go to EMT school to learn that. That's why we have to get that while we're on scene. It's important for us to try and get that. Talk to people. Did anybody see it? Do we have any evidence on scene? Is the patient talking? Can they tell us what's going on? And when we go back to the car accident, when we have a car accident, the curriculum goes with 3 different collisions. I'll tell you another thing that I think is fairly important is, from your perspective as a student, is when you talk about trauma, or when you like Google things, you can see a whole bunch of different discussion forums and different ideas of what's important in trauma. Can you take a tourniquet off? Do you always have to leave them on? What about mask pants? What about surgical airways or RSI or whatever? There's going to be all kinds of different opinions. What do you need to know as a paramedic student is what you should be focused on, right? And what your focus, and truly even there's differences in between Brady book and our Jones and Bartlett book, all right, on what you might think that you have to know. A go-to document would be PHTLS. The National Registry probably likes PHTLS as much as anything else. One example of why that's important is like if you read an ITLS book, it will say that we should be maintaining a blood pressure of 110 for all TBIs, all right? And the PHTLS and almost everybody else stays with that 90, all right, that we do for trauma and hemorrhage. So that's kind of a weird thing. I like the ITLS thing better. I really do. It totally makes more sense. But PHTLS doesn't say that, so I don't teach that, all right? We need to focus on what National Registry will say, and the go-to, you know, the source, the horse's mouth, so to speak, is your most current PHTLS book. And it's probably true about all of the National Association of EMT stuff, NAEMT. They do something on geriatrics and pediatrics and tactical medicine, and trauma is probably their go-to, where this makes the most sense, because if you can go to AHA for your resource document, that's it. That's the resource that you want to go to. But they don't talk about trauma very much at the American Heart. So NAEMT's PHTLS is probably where you want to go. So here they talk about this, the 3 collisions in a PHTLS book. Truly, if they didn't, I wouldn't have this slide. All right. We're going to have probably one quiz question on this, and then we're going to be done with this information. When we get into a car accident, they just want you to realize and think about, there's first, your machine is going to, you know, the way that energy is applied is first you have your car going into a tree, and then you have you as an occupant moving forward in the car. It's a frontal collision. And the next thing is your organs also then going forward and then maybe ripping or tearing while they're in your body. Those are the 3 different collisions they talk about. And here for the next 5 slides or so, we're going to go through the different ways that we can get in car accidents pretty much. When we talk about frontal and head-on, remember they use those terms intermittently, and almost always if you say somebody was involved in a head-on collision, the way people perceive that is 2 cars went head-on. Does that make sense? To me, that makes sense. The way we use these words, that we're supposed to use these words, is no matter how the collision happened, if this guy hit this guy here, this guy was in a head-on collision. He was in a frontal, probably a better term to use, a frontal collision. This guy was in a lateral, all right? So it's fairly important to get that right, so people who are listening to your story know like what you're talking about, how the principle of direction of force was applied to the patient's body. And when we're in frontal, no matter how we can frontal into a tree, we can, depending on how our body is and how we sit in our seat, we can go down and under. If you go down and under, the expectation is their knees hit the dashboard kind of stuff and push the femurs out the back, all right? So you end up with maybe pelvis fractures and hip dislocations and hip fractures from a down and under pathway. The next thing that's going to come forward, which is much less now because of airbags. Airbags don't save you from this that much, all right? But airbags do make it so your chest and abdomen aren't going to be so bad, all right? And then you can bang your face into a steering wheel. Yeah, that doesn't seem like you could bang your face into a steering wheel. Seems that way to me. But they don't talk about that, all right? They don't usually talk about head injuries and facial injuries with the down and under pathway. They focus on the idea that you'll have that your femurs getting blown out your butt, and then your head or your chest and abdomen. Up and over, it's all about C-spine in your head, because you're going to be hitting this one. I like the way they did this, because almost all of the time it is way up here. You get that star way up here, and sometimes their head is actually hitting where your visor is, all right? So it's not a bad thing to look at too, as they're coming up and out of their seatbelt. Seatbelts shouldn't let you go too far up and out. And again, so when we look at that, we're of course going to say face, head, spinal, and then neck and chest and abdomen are also. But his knees are probably fine, right? His femurs are probably fine. His pelvis is probably fine. A lateral impact, the thing that makes frontal impacts so bad is we very often talk about it being a high rate of speed, all right? Especially when we're talking about head-on, as in one car going head-on into another car and they're both traveling. What makes it so we survive frontal collisions nowadays? What helps it? If we compare it to lateral, which is the worst kind. What is it? Seatbelts, what else?
Crumple zones.
A crumple zone. We have a good crumple zone. Well, we always had a crumple zone. We didn't have to have it built for us. It's just like there's a lot of space there, and we have a big old engine there that's going to save us. And ever since the 80s, we've been making airbags, right, for those. Like some of us have side impact airbags, right? Not me, all right? I have two in the front, and that's it, I think, as far as I know. I have a roll cage, though. So when we're in frontal accidents, we have much better safety stuff. Safety stuff is going to help us as long as we're using it. Lateral impact, we have a minimal crumple zone. Some of us don't have airbags at all. When we do have our airbags, it's not that big of a airbag if we're in our Focus and the guy hit us with a F-250, all right? It's just not going to make that big of an impression. And then I think that's about it, right? And lateral hits are the ones that's how people die, all right? Getting hit in the door by a larger vehicle. A rear impact, we talked about this during the quiz, it's all about whiplash injuries. The rest of our body usually does really well, all right? So it's all about neck injuries, and maybe if our head went into the steering wheel, facial injury, head injury, but most of the time, that doesn't happen, all right? Most of the time, it's just about whiplash. Rotational is when you get sideswiped. It also is, so that could be when you veered off the road and then the back of your vehicle, or even just let's say the side of your vehicle hit the tree. What that will do is it will knock you out of where you're supposed to be. That energy will be applied to your body, and you now will not be sitting down nicely in your seat. You'll be outside of where you're supposed to be. Your seatbelt just tugs for a second, and then it's done, all right? Then you can go back to pulling it and moving, and your seatbelt's not holding you down anymore. If that energy was applied in a way where, because of the forces applied on the car, your airbags went off, airbags go off. They only go off once. So now those went off, you're not in your seatbelt the right way, and then you have a secondary hit. All right, so the problem with rotational is that second hit can be super serious because none of your mechanisms of safety are going to really help you. Some of them you may make an argument will actually hurt you more because you're outside of where you're supposed to be. And then the last one is going to be a rollover. Has anybody here seen somebody in a rollover accident? And how did they do? What's that? You've been in one? How did you do? Did you get flown in a helicopter prior to you went to Butterworth?
Depends on which side, because if they roll, they fall out the window. We've seen that there's nothing but the guy that's falling out that way.
If you stay in the car, you do pretty well, all right? So most of the time when people are in rollovers, they're like brushing themselves off when we get there and they're okay. They climbed out of the car and everything. When they get thrown out of the car, that's a different thing. So again, when we're talking about energy being placed on the body, when we're rolling our vehicle over time and space, that absorbs the energy. It's not like that landing when we fall from 25 feet, boom, very short time of impact. So it's more energy applied to your body. When we're rolling, as long as we have our seatbelt and we're just staying in the vehicle, we're maybe getting hit by our Coca-Cola, and that's about it. We're probably going to survive that. And this swaddle triad is kind of a weird thing. It really, I'm going to kind of poo-poo it a little bit. Some people like to talk about it a lot, but when you're talking about kids, and the swaddle triad is for kids, but we can associate, I think this is a good one to associate with what's the difference between kids and adults. So what is the difference between kids getting hit by a car and adults? What are the predictable things that are different?
Kids have a big head.
Kids have a big head.
Hit their head.
Good. They could get a head injury, but adults can get head injuries too.
Adults are more likely to turn away and then end up over the vehicle. Kids take it anyway and go under the vehicle.
Good. So kids will face the car. All right. Kids do not understand brakes and inertia, and they're surprised usually by the car. They've ran out on the road, and then they'll look at the car and basically be saying to themselves, stop. Adults kind of understand, oh, I'm about to get hit. And so they try to run away from the car. And so when they get hit, they'll get hit here, and then they can go up on the car. And then where is it that you're gonna get hit? Here. It all depends. How tall are you? And what does the vehicle look like? It's the same thing for kids. How tall is the kid? And what kind of vehicle is it? Most of the time, when we're talking about kids and waddles, if that bumper was at their pelvis, they have a pelvis fracture. If their bumper was at their femur, they have a femur fracture, all right? They'll go up into the car, and the chest and abdomen will hit the car also, up on the grill or whatever, and then the head strikes the vehicle or the ground. So it really isn't that helpful, all right? It basically says kids get hurt all over the place, just like adults get hurt all over the place. It's hard to predict. You have to look everywhere. It's hard to say, oh, he's just gonna be hurt on the left side or the right side or whatever it would be. You have to look everywhere and suspect all of these different things could be injured. Since kids are closer to the ground, when we have a higher truck or such, it's more likely that they'll end up underneath the vehicle also. That kind of makes sense. When someone falls from height, like 20 foot or so, adults usually land on their feet. It's true if we're conscious, we know what's happening, like when we have people who fall off the house and when they're roofing it or whatever, they're usually trying to scramble, boom, boom, boom. When they fall, they land on their feet, all right? Kids, again, dumber than we are, they don't say, oh, I have to land on my feet, that'll be safer. They're like, whatever, this seems more enjoyable, head first, all right? And since their head is more heavy, they land on their brain housing group earlier, or more often than what we do. So here, I'd like to go, sure, this is all, what we're talking about is mechanism of injury, energy placed on the body, gives us an ability to say, oh, these are the probable injured things. So if we have somebody fall on their calcaneus, here we have a little fractured calcaneus heel bone. When that is true, they probably also have a lumbar fracture, all right? Because that energy very often displaced. The next place that there's a movement, that there's a vulnerable place is like L4, L3. Somewhere in there was the S of your spine that will go, whoop. So maybe if it's not a fracture, it's at least whoop, your discs came apart or were compressed down. If she probably doesn't have a head injury. And her upper extremity, gonna be fine, all right? Probably not a chest injury. She could be bleeding in her abdomen if we end up with pelvic fractures and things of that sort. But her chest and neck and head, probably fine, all right? If she lands on her head, again, you don't have to worry about her feet like we saw on the earlier slide. When we get to the hospital, we should realize those guys don't want to talk about her allergies. They don't want to talk about all the other stuff. They want to hear the first thing that you're supposed to talk about is the mechanism of injury, and this is what they're looking for, all right? These big three, and you could go with there's maybe big 4 or big 5. 4 would probably be, why did she fall? Like, did she lose her, was she unconscious first and then fell? Or is this a slip and fall kind of thing? Why did she fall is kind of important. You guys remember what number 5 is for me? Number 5 is, can you guys think of? There's 2 other things that are kind of important. One is, did she lose consciousness when she fell? Did she lose consciousness before she fell? Did she lose consciousness after she hit the ground? And then did she get up and walk afterwards? All right? If somebody fell and then boom, hit the ground, a good description of what happened. Did she get up and walk over to the bench and sit down? Well, if that's true, her tip fit's probably intact, all right? She probably doesn't have fractured femurs, and her pelvis could be good to go, all right? If she just got up, walked over to a bench, sat down, and started complaining. Make sense? Because most people with femur fractures don't like to walk, all right? So if somebody walked, that's another important thing to say. Did you rule out, and there's no way that there's a femur fracture? No, no. You can have a femur fracture and you can walk on a femur fracture. It's just not normal, all right? So you should still check. You still have to look and such, but it's not normal for people to walk on pelvic fractures. I've had people walk on pelvic fractures, 100% for sure. We used to have the academy in the basement in Jenison. Somebody brought their granddaughter in for a look. When they left, she fell going up the stairs, kind of like our president does every once in a while. So her daughter came down, got us. I picked her up, helped her to her car, and she ended up with a pelvic fracture. Not a hip fracture, a pelvic fracture. So I was like, wow, let's not let that one get to the radio. We're helping people not go to the hospital. Everybody good? But it helps you focus where you're supposed to be looking. This is gunshot wounds. You guys all good for going? We've been here for an hour. So gunshot wounds, is everybody feel pretty good about ballistics? When bullets are big and moving slow, they cause less damage than little bullets moving fast. When they enter our body, there's all kinds of different ways to go with this. When we're talking about National Registry, we should think about the normal, like the bullets they had in the 90s and the 80s, all right? Don't be thinking about fragmentation things and all kinds of things. You can think about, they might talk about a mushroom and things of that sort, but it doesn't make that big of a deal for us as far as, well, if it was this, and you very often don't know that. The only things that you know from the police officers is they'll say there's 9mm casings, and they won't go, and I've seen these casings before. This one goes with, this kind of thing. It's definitely, 65 grains of this and a, hollow point of that and all of that. When bullets enter, there's a definite cavity that's going to go through. Where the bullet went through, there's going to be a thing. We could stick a rod through there, right? But what people may not understand, all you guys do, is while that energy is going through there, everything is expanding, and it's also maybe breaking up bone and pulling everything through this temporary cavity, and that is what's ripping apart organs also, causing hollow organs to maybe spill contents or solid organs to be bleeding. That all makes sense, right? Shotguns is one that is a little bit off, and I don't think the National Register is going to talk about shotguns for some reason. But shotguns can be bird shot, and that's a bunch of little pellets, right? Very often they end up, people who get shot with that get shot from a distance, whether a hunting accident, and people don't go, I'm going to protect my house with some bird shot. People don't usually do that. They want to really knock you down. So bird shot isn't the thing to pick up. They do shoot at people like, get off my lawn, boosh, bird shot, and it's just gonna hurt like hell, all right? And I've had people who shot with that, and like the BBs are right there. They're like little red dots with blue bruises around them, and you can feel the BBs underneath their skin. The next is a sabot round or a slug, and that's just a big old slug, all right? It's gonna make a big impact on your day. Very often, when we're getting people hit with those kind of shotguns, it isn't a home defense type of thing. A lot of those gangbangers aren't walking around with shotguns anymore. They like to shoot lots of stuff. They're too lazy to do this too much time. So shotguns aren't a big thing. Like, people don't go rob banks with shotguns. They usually just bring pistols because they're small, all right? They're easy to get around, get into the bank without everybody knowing that you have a big weapon with you. It's the same thing, like ARs and AK-47s. Most just regular old crimes that people are trying to do, they don't bring those big guns. They bring those to gang fights and they bring those to schools to shoot kids. That's it. People who get shot with those kind of things. Like, has anybody had a shotgun? Like somebody who shot with a shotgun? And what kind of scenario was that? Was that?
White trash romance. Walked in the wrong house. Took a buckshot around to the legs. They blew his ankle off.
Wow.
It was a pattern. It was about 20 feet.
20 feet was big, like
The buckshot,
triple,
they're like big, like marbles.
Yeah.
So he took most of the pattern through the ankle, so found him in his truck with his foot hanging up over. But he had about two in the left leg and his thigh, and about 3 throughout his other.
from one gunshot.
From one gunshot. They usually come with a couple. Buckshots usually 6 to 8 BBs in it.
Does that make sense? So little BBs, bigger BBs, like those bigger BBs are like the tip of my pinky, all right? And there's like, triple op buck and all of that. There's all kinds of different things. Get that, just, and those spent casings will probably be on the scene and the cops will know. And so you see, oh, there's a hole, and there's a hole. Makes sense? It's a lot of energy when you're close to it, but shotguns aren't really great. You can ask a lot of deer. You can knock one of those down from quite a distance. But it's just not something that I don't have a lot of quiz questions, test questions. I don't think the National Register is going to ask you much about shotguns. Make sense? The bullets move slower. They're big bullets, all right? When you get shot with them, it's a home defense gun. It's really kind of an underrated home defense gun nowadays. Just listening to somebody rack around is going to be like, boop, I'm out. That's it. So but when you get hit with them, it makes it'll make an impact. It's a lot of energy in one place. And then these blast injuries we talked about already, right? One thing that I like to bring in here is when we're talking about this, all of this stuff that's not really new, but this is new to our curriculum from 2001, 2003 timeframe, where we talked much more about blast injuries. Most explosions that would just like this guy's house filled up with gas and then blew up, or his RV filled up with gas and blew up, or he had gasoline and he threw it on a fire and it blew up, and those things are not these. This is called a high order explosion, and then they're not going to use that on the National Registry. But when it's a purposeful explosion, when somebody put together a bomb, all right, they do that. It's a high order explosion. They make it so these things are true. When you have a house blow up because of a gas leak or something, these things aren't as true. You can still get burned, right? You can still have problems. You can still get hit with shrapnel. But when we're talking about primary blast injuries, it's a terrorist event or somebody who's making fireworks in the Grand Rapids or Holland area. That seemed to be one of those things too. When you're making a pipe bomb, that's a high order. That can be a high order. It should be a high order explosion. When that happens, this primary thing is the first thing, and that's just changes in atmospheric pressure in your body. So the hollow organs or hollow spaces are what get injured. So it's an ear problem, a lung problem, and you can have spaces in your gut, so you can have blast gut too. We talked about secondary, getting hit with shrapnel. Tertiary is your body getting thrown against something. The quaternary, which is the fourth, is the building landing on you. And this is where burns come up too. And a lot of times people's perspective of explosions is there's a big Quentin Tarantino style flash of fire. And I think a real good, just to get like, you don't have to trust me on this, but the footage of the Boston bombing, they actually have cameras that showed Boston bombing, and you don't see any flame. You just see dust and people getting kind of thrown and such. So you usually don't. If you throw a hand grenade in army training, boom, it just goes boom, makes a big loud noise, but there's no big flash that everything starts on fire and things. It's just no fire at all. You just see stuff move. All right, that's it. A bunch of dust will rise up. You can get burned. All right, so not primary, not secondary, not tertiary. These burns come from the idea that stuff can start on fire. All right, when you blow up houses nowadays, you're going to be upsetting electrical and gas mains. All of that kind of stuff can be burns, and some explosions have gas in them. Some are known for burns. Respiratory injury, then crush injuries, entrapments, all of that, crush syndrome. And then quinary is the last one. All right, so quinary is biological, chemical, radioactive stuff that they've added to the bomb. And then there's the criteria for a trauma center. So this is something like in Michigan, we don't really have a trauma system or coalition that has a bunch of strength to it. But in other states or other regions, they'll have rules like if this is true, the person has to go to the trauma center. You have to ask permission not to go to the trauma center if there was 1 foot of encroachment into the passenger compartment. So this is one of the discussion forums. So the first one is the 2011 field triage, which came out in 2012. It's the CDC thing. That's the go-to. That's what would be on the national registry. All right, and then they have different criteria there. The first criteria is just vital signs. All right, respiratory rate, pulse rate, and then blood pressure is the big one. If they show the signs of shock, they're priority, then you start to say, oh, they should go to level 1 trauma center. The anatomical criteria, which is a little different from that thing, is about the same as this. Penetrating injury to the important areas, chest wall instability, which is basically a flailed chest, 2 or more proximal, so long bone fractures. If you get a humerus and a femur, you're a priority 1 patient. Crushed, mangled, and pulseless extremity, amputation proximal to the wrist or ankles, pelvic fractures are all level 1 criteria, open or depressed skull fractures, and then paralysis. So some of these don't make sense because paralysis is paralysis. That's not going to get worse. There's no reason to go so fast with them to get them to the hospital. Don't dawdle, but there's no reason to go license irons, and you don't usually need to go right to surgery for those. It's kind of a nursing thing as they're starting to do hypothermia stuff and corticosteroids now. The same thing is here, this crushed, mangled, or pulseless extremity. If it's 1 extremity, it's not that big of it. It's not going to kill them one way or the other. The emergency surgery, they'll have surgery that day, but it doesn't have to be that big of a, if you don't get here in 5 minutes, you're going to die kind of thing. It's still going to be planned out pretty much. The MOI criteria, this is about the same as what you'll see on that 2011. Adults, it's more than 20 feet. Children, it's usually more than 3 times their height. 12 inches of intrusion into a passenger compartment, getting ejected, pedestrian who's hit, motorcycle crashes when it's 20 miles an hour or more. And then the special considerations, the big one here, they all kind of make sense, too old, too young. And then the anticoagulants, of course, and the pregnancy, or the anticoagulants, I should say, by itself, is the big one nowadays, all right? We talk about that more than these other things. It's, a big part of our protocol in the area. Some other things to think about, adults hurt themselves, stand, at ground level falls. Sometimes that's a priority 1 all of the time. To me, that shouldn't be. They don't have to go to trauma centers all the time, but we should have a high index of suspicion that it is something. The research has shown that, all right? This afternoon we were talking about this, and Butterworth actually says, that's a trauma call down if you have a forward fall for a geriatric patient. I think it's older than 65, like 75 and older. Fall forward from ground height, that's a trauma call down. So the burns, just to think about this, is when you, here, doesn't matter, just go to Butterworth, right? Because the burn center and the trauma center is the same. In some other areas, the burn center may not be a level 1 trauma center. They're probably a level 2 trauma center. But if that's not the case, the way the National Registry looks at this is you as a clinician that have to say which one's worse, which one's gonna kill them, all right? Should they go to the trauma center to get stabilized and then go to a burn center? That's probably the way you'll go if it's bad trauma, all right? Burns, but you know, if it's just burns, that makes it easy. But if it's burns and chest injury, abdominal injuries, head injuries, those things, maybe going to the trauma center first would be a good idea. And here's the helicopter. We have a whole thing on EMS transport, so we don't have to talk about this too much, but having a helicopter does make sense, right? Who do we call when we, what kind of patients do we have, or what kind of situation are we in when we think, let's get a helicopter? Prolonged entrapment. That one's a fairly important one for, like, if we're in Kent County, right? Because if the patient's already out of the car, if we just put him in the ambulance and get going, he'll be in the surgeon's care quicker than if we were going to take him via a flying ambulance, right? And we should always accept this. It's all about, in real trauma, paramedics don't make that big of an impact, all right? There's much better data that say EMTs if you're cared for by EMTs, you have a much better chance of survival compared to being treated by paramedics, all right? Chicago has one where it's the taxi drivers beat out everybody, all right? So that was a bullcrap thing, but it's actual research that showed if somebody arrives via taxi, they have the best morbidity and mortality things compared to EMTs and to paramedics. Canada has some true, you know, like it really makes it look like, wow, we're lucky that the insurance still pays for us at all. Who saves the patient are the surgeons. So really what we should put way high at the priority list is this guy has to get under a surgeon's knife. We have to get that. So having nurses and doctors and stuff like that on scene might not make an impact at all if they're not able to get them to an actual surgical suite. So one, we should have some sort of entrapment, all right? Not always, because we could just be a huge distance away from the hospital, and maybe then it's a good idea to call that, because remember, we're not just in Michigan or even Montcalm County. We could be in West Texas, all right? And then it starts to make sense to start sending helicopters much more, because it's an hour or two via an ambulance and a half hour via a helicopter. Why else would we say, oh, let's get a helicopter?
Hemorrhage. Prolonged bleeding, or
What would the helicopter have for that
have
program?
blood.
They have blood, all right? So if you're stuck, one thing a helicopter, you're stuck. You can't extricate, the patient's bleeding, we can't compress the wound. One thing to remember is a helicopter very often can bring blood. What else? What else does that flying ambulance have that our road ambulances don't?
Or faster.
Faster.
Some of them, don't they have doctors and surgeons? I think.
Yeah, it's very rare. Most of the time it's going to be a nurse paramedic. Sometimes here we have nurse. We used to have a nurse doctor. They probably bring better airway care. All right, it's much better chance that they're going to have RSI and experience behind that RSI to get the patient intubated and ventilated. They're going to bring extra drugs. All right, they're going to have things like propofol. They're going to have refrigerated medications. They're going to have experience with that is the biggest thing, right? Not only just the drugs, but then the experience behind using those drugs is what's important. With the blood, and then that's it. You know, like there's maybe 1 or 2 helicopter systems that do REBOA now, which would be the bleeding thing. I'll have a slide for that later. But other than that, the other thing for helicopters is helicopters don't like hazmat and they don't like dead patients, all right? So they usually don't transport those. I once transported somebody who had a broken neck, all right? And when we would roll the guy, it was before we got there, I did it too, but when they would roll the patient onto the backboard, there's firefighters probably in the Allen, that was by Grand Valley State University, when they roll them back onto a backboard, not right away, but after about less than a minute, he would go numb. And he would have a lot of pain in his neck. So they rolled him back off from the backboard. They did it twice. Boom, happened again, so put him back up. And when I got there, they said, for me, I was working at AMR, that's life's territory. It must have been a good 30 minutes that they were on scene. So I was like, boom, we're gonna get there. It's not gonna be such a bad late call. You'll be packaged, we'll throw them in the ambulance and we'll get going. Nope, they were in there, there's just like 18, you know how firefighters can be, there's about 18 of them there, just smoking and joking, and one of them was over the C-spine. I'm like, why is this guy not backboarded? And you know, this one, it's encouraging. This guy was super rich, like we had to bounce down a quarter mile to a half mile 2-track driveway to get to him. And big old sweet house. And he was working on his basketball net and rim and backboard and such. And so he had his own tractor with a bucket and then a ladder that he put on, and he strapped it down and such. So this gives me potential. You don't have to be so smart to get a lot of money. And he climbed the ladder until it fell over, and that's how he landed on his head onto hard ground, pretty much. So I was like, if we put him in the back of the ambulance, I'm all for, I can immobilize this guy on his side. I'm liking that. But then I have to bounce him down his driveway, which is good. Truly, it was more than a quarter mile to get back to whatever street we were on, really close to Fillmore. So I said, let's call a helicopter. How often do we get to do that? So we landed the helicopter, put him on there, and they took him to the hospital. He ended up getting, I always want to think there's a happy ending to this story, but it wasn't. He ended up with secondary things where he was paralyzed in a wheelchair for the rest of his life, pretty much because of probably all of us going, hey, let's do this, let's do this. Just kidding. But yeah, he had continued. I was expecting to get good data on him because he had feeling. Everything, as long as we immobilized him on his side, he was good. There was nothing else going wrong with him. His blood pressure was good, pulse was good, everything was, he wasn't in the spinal shock thing or anything like that. But he ended up developing all of that when he was at Butterworth.